it's true. I'm afraid they'll come and take away this precious dream you. Then you wake and hold me and love me through the night. Then I know that somehow everything will be alright. Thank you, baby, for giving me my life. I love you, honey, you've given me my life. Thank you, baby, for giving me my life.
Okay, good morning, everyone. I'm unmuted, right, guys? Can folks hear me?
We're all muted and we all have our videos off.
Okay. But I'm on. I mean, can other folks hear me? Yes. So people are saying that they can hear me. Great. All right. So um, um, people are texting me saying that they can hear me. Great. All right. So should we kick off? I'm seeing we've got about 64 participants. I know a lot more folks had registered. So I'm going to just sort of start by saying good morning to everyone. I really want to welcome you all and thank you for being here today on this reboot of CBC's Innovation Conference. As many of you may recall, our Innovations Conference, our second Innovations Conference, was scheduled for March 11th. And the week before, we really struggled about what to do. And we obviously ended up canceling it. At the time, the concerns and some of the issues related to a potential lockdown were still kind of up in the air, but we made the decision to cancel it. And here we are 7 months later, and a lot's happened in those 7 months, but we really wanted to think about and reimagine what sort of a conference would look like in the age of COVID. So we decided to put on these web series so we can really shine a spotlight and acknowledge all the hard work that went into the second conference, in terms of developing the posters and the panels and all the work that went into that. So we really felt it was important for us to really acknowledge and shine a light on all that work. These virtual panels will be focusing on some of the most relevant topics in the field, but also addressing the impact that COVID has had on your agencies, your staff, the service delivery models, and most importantly on your clients. I do want to start by thanking the CBC team that's worked really hard on pulling this off. This is all uncharted territories. If putting a conference the way that we did, the more traditional way was really hard. This has been, even more so challenging, given that we're all remote and we're really trying to figure out the new technologies and how to make this as user-friendly as possible for everyone. So I want to thank, Mark Graham and Alexander Wolf and Emily Grossman, Juliana Steen and Allison Oswald for all the work that they've done. I'm certain that these web series will be a source of valuable information for the providers, but also an opportunity to really shine a light on the great work that many of you are doing under such difficult and trying times. As many of you have heard me before, now hopefully you have, really talk about CBC being incredibly committed in becoming an innovations hub, where we're going to hopefully be able to identify these practice-based approaches and work with network providers on improving quality and outcomes by supporting the work that you do and really trying to become the premier behavioral health network in the city. I'm a strong believer that healthcare is local and needs to be person-centered. And I believe that agencies like those that CBC represents really have a critical role in determining how healthcare needs to be transformed at the community level by identifying and disseminating more of these practice-based approaches that many of you are doing, that have proven effectiveness and have achieved really amazing outcomes. We're currently in the midst of significant challenges, at the national level with an upcoming election, but certainly the current and longer term impacts of the coronavirus, a huge hole in the Medicaid budget with looming withholds and cuts, and serious disruptions in how healthcare is being organized, delivered, and financed. Since the last innovation conference, CBC has continued to evolve and grow and find ways to better address some of these challenges by creating value adds that really will help the community-based organizations that we represent. We have strategically pivoted to 3 fundamental pillars of impact that we can deliver on: sustainability, quality, and innovations. First and foremost, CBC, representing a network of providers such as you all, whether as a health home or an IPA, or the contract holder for some of the innovative programs like Pathway, we've been focusing on quality and improving the quality of care for those that you all serve. We are now knee-deep in the implementation of our Arcadia-powered data analytic business intelligence, DABI, platform. We have defined a core set of measures, and our quality department has been, under the amazing leadership of Tracy Jones, been able to really work closely with many of you on the different committees to develop these measures and create performance report cards that we will be disseminating soon across the network. In addition, we've expanded training offerings under our training institute headed up by Emily Grossman, and we'll be continuing to provide technical assistance training, learning collaboratives, learning networks that will enhance quality across the board, across the entire network. Through an OASAS grant, we launched Project ECHO, which has been widely successful in disseminating critical competencies via case conferencing and didactic learning aimed at increasing access to medication-assisted treatment for those with substance use disorders and opiate use disorders. Sustainability remains a key challenge for our network, and we have continued to pursue contracting opportunities with managed care organizations with some limited but important successes. We have Pathway Home Team now funded by Health First, targeting the Medicaid and Medicare population, as well as an innovative ambulatory detox and withdrawal management pilot with Health First. We're also embarking on conversations with Metro Plus as they bring in their behavioral health services in-house. We've successfully finalized contract amendments to 8 of the providers with Empire and their behavioral health quality incentive program, as well as we were successful in negotiating contracts with Health First, Empire, and Emblem for the HCBS infrastructure, which albeit is winding down now, but that was a really important experience for us. We continue to meaningfully engage other IPAs, hospitals, and many of the managed care organizations on contracting opportunities. Continuing along the lines of sustainability, we partnered up with CBHS IPA, who's I see some of the folks are on this call, to develop innovative management solutions NY, IMS NY, that is a joint venture MSO between the 2 organizations. And really, we've been able to anchor under IMS NY the Arcadia platform as we're building that out, as well as developing other potential lines of business. Through IMS NY during the pandemic, we were able to secure and provide over 500 Zoom and DoxyMe licenses at reduced prices for our providers, and we're hoping to be able to do more of that. The Innovation Conference was supposed to be about showcasing many of the innovative approaches developed by providers to improve services for their consumers and that have the potential for changing the delivery of care models in New York City. But COVID has completely upended that and changed everything we know about health, wellness, safety, and even service delivery models. COVID has had a huge impact on how we engage with our clients, and providers had to make a very hard and very fast pivot to telemental health platforms, which many are still using. CBC disseminated a telemental health position paper a few weeks ago. Hopefully the link will be, oh, there it is. The link is in the chat box for anyone that has not had a chance to see it. It's up online, where we're advocating for the continuation of regulatory waivers, administrative flexibilities, as well as an emphasis on enhancing workforce capabilities, and most importantly, fair and equitable rates and payments for telemental health services by the plans. COVID-19 has also had significant impacts on the population in general. We were successful in getting a grant, one of the SAMHSA COVID emergency grants with OMH and OASAS and CBHS. And part of it is really about trying to figure out how we're going to not only support the providers and the individuals impacted by COVID, but also thinking about the workforce. We know that anxiety, depression, and children's behavioral health as measured by the percentage of adult New Yorkers that endorse these, have really increased dramatically. Access to services have also been impacted. 14% of adult New Yorkers reported an unmet need for mental health services since the stay-at-home order was implemented, and 15% of adult New Yorkers reported difficulty accessing mental health services for their kids during the same period. COVID obviously has laid bare the serious impact of underlying health disparities on Black and Brown communities. Individuals experiencing additional stressors and traumas related to COVID-19 and structural racism may be more likely to experience adverse mental health impacts, and a lot of that's borne out by some of the research in prior disasters. With about 5.5 million MHA screens, and there's this recent study that came out, completed through June, we're seeing that over 170,000 more additional people compared to baseline have screened moderate to severe in terms of depression and anxiety since the start of the pandemic. The mental health impacts are not just on depression and anxiety. We're also seeing steep increase in the number of people endorsing psychosis, as well as significant impacts on individuals under the age of 25, where roughly 9 in 10 of the screenings reported moderate to severe depression. Coronavirus has further exposed vulnerable populations, including those with opioid use disorders. Research shows that the recession from the pandemic may lead to about 75,000 deaths of despair from drug overdose, alcohol abuse, and suicide. Reports of opioid fatal and non-fatal overdoses have spiked in some areas across the country since the coronavirus pandemic began, reasons for which are, we know, multifaceted, but in part due to reduced access to healthcare and recovery support services. Even before the COVID-19 pandemic, New York State was dealing with the growing opioid epidemic, and now we are experiencing an uptick in opioid use and overdose fatalities. There was a recent thing that came out in this morning's Cranes about Fair Health. They publish a lot of the claims data on telehealth, and what they're showing is that in the Northeast, the use of telehealth has obviously, exploded since the pandemic began, but SUD disorders being sort of the reason for the claim for the telehealth service is among the top 5. The number 1 being actually mental health disorders. So these are really serious conditions that are gaining a lot of attention and traction in terms of interventions via telehealth. We decided to launch our innovations panel, our innovations conference in this panel with this aptly titled, When a Pandemic and an Epidemic Collide, with providers and administrators to discuss the impact that COVID-19 has had on the opioid epidemic and describe some of the efforts underway to enhance access and utilization of medication-assisted treatment for opioid use disorders in the context of this pandemic. I truly want to thank our amazing panelists and moderators for what I know will be an interactive, insightful, and stimulating discussion on this topic. Sarah Lawrence Tacky, the medical director for the methadone maintenance treatment program at Greenwich House, Erica Anaga, the chief program officer at Chazy, Kelly Ramsey, who's the associate chief of addiction medicine at OASAS, and our panel moderator, Carol Ann Slattery, who's the VP of outpatient services for Samaritan Daytop Village. Before we launch, though, into the panel, I did want to highlight some of the posters on innovative practice-based approaches that were submitted for our March conference. SUS, Services for the Underserved, had submitted a poster on successful engagement strategies for opioid use disorders in their Certified Community Behavioral Health Clinic, their CCBHC, where they were able to provide integrated substance use and mental health services on site. The focus was to fill the gap and assist with improving overall client health by increasing access to mental health and substance use treatment, as well as directly responding to the epidemic involving those that were struggling with OUD. With expansion of their staff to include peer specialists and case managers, they were able to deliver person-centered, trauma-informed, recovery-oriented services that were accessible and available both within the clinic and in the community. This enhanced service team allowed for greater flexibility in regards to community outreach, treatment discharge planning, and community supports for individuals in varying stages of change regarding their personal recovery journey. The initiative has engaged, and this was back in March, I'm sure there are more since then, has engaged over 1,100 individuals with OUD with an 86% success rate in patient initiation and continuation of MAT. Again, really amazing outcomes, and we have to figure out how do we disseminate and replicate those even further. Greenwich House had submitted a really interesting poster on integrating hepatitis C treatment into a community-based opioid treatment program by creating a program that provided on-site treatment for hepatitis C to all those infected patients, taking advantage of the opportunity in an OTP setting to treat a population that was in need and that sometimes doesn't seek care elsewhere. It's unclear, or was unclear, if this practice had been evaluated in a community-based outpatient treatment program. There is some literature that shows hospital-based OTPs, but not certainly in community-based. And what Greenwich House was able to do was really develop an innovative model that allowed individuals to initiate treatment on site. So through March, 21 patients had initiated treatment, 10 had completed their full treatment course, and of those, 9 had been cured of hepatitis C, resulting in a 90% cure rate for this model of treatment. Samaritan Daytop Village submitted a poster on moms, maximizing opportunities for mother success, which was funded through a SAMHSA grant. And this program expanded on a residential substance use disorder treatment program serving pregnant and postpartum women and their children up to the age of 3. The MOMS program was a trauma-informed treatment model that uses evidence-based interventions to address substance use, mental health, parenting techniques, and family reunification and community reintegration. Through March, the MOMS program had served 99 mothers, 90 children, and 18 family members. On average, MOMS participants remained in treatment for 227 days compared to 135 days for clients in other residential programs, and 55% of discharged MOMS participants successfully completed treatment compared to 49 for more traditional methods of treatment. Another Samaritan Daytop Village innovative program was the Substance Use Therapy and Recovery Treatment, START, which was developed in partnership with Health First and Coordinated Behavioral Care, CBC. The START program targets key barriers to accessing treatment and sustaining recovery by providing transportation, peer recovery services, and an individualized care plan for each client. START is innovative in that it engages clients directly from the hospital and transports them to an outpatient program to begin the admission process and reduce the time clients wait to see medical and admission staff to initiate Suboxone. As you can see from these posters, and there were plenty more, and all the different projects that the network providers are involved in, that providers in the community are finding ways to engage and support their clients in innovative and successful approaches that must be evaluated and replicated across the network. And that's our commitment at CVC, to really try to do some of that work. As a network of providers, we must start to learn from each other and adopt new delivery models so that we can become truly a clinically integrated network and can start that journey. And we're going to start that journey today with this panel and conversation. So I'm really excited to kick this off today and introduce you to our moderator, Caroline Slattery, who will get the panel underway.
Thank you, George. Good morning, all. And I'm just going to expand a little bit on what George was speaking about. So since March, COVID-19 has in many ways overshadowed the opioid epidemic in the public eye. Yet we all know this crisis remains. Entering into a pandemic during the opioid crisis, state and federal realized a true collision was going to occur. So recently, the American Medical Association cautioned that at least 30 states have reported an increase in opioid fatalities since the start of the pandemic, and one of those states is ours, New York. The opioid crisis is challenging, and under any circumstances, it became increasingly more challenging when we add what's been happening with this pandemic. So as we know, people are dealing with anxiety, grief, isolation, and changes, between home, school, and work. There have been so many financial worries, and there's just an ongoing sense of uncertainty. And as we know, the unhealthy responses to these stressors can lead people to turn to substance use. So this is difficult for any of us, but people with opioid use disorder and in recovery are facing unique challenges. The federal agencies that regulate access to opioid use disorder medicines have implemented a number of flexibilities to make treatment more accessible. So for example, telemedicine, as George was saying, is being used for some aspects of treatment that would typically require an in-person medical visit. This actually helped us treatment providers and the clients because it allowed patients to obtain larger supplies of the medications. So the option for telehealth has been critical for some people. Although it has been extremely helpful, others, it may not have been an option. And so for others, that they may feel it doesn't have the same impact as having that face-to-face contact with healthcare providers. But as research is moving on, we're definitely paying close attention to the outcomes of these new flexibilities. And because if the outcomes are good, this may be a way to improve access to treatment in the future. We all know COVID-19 has transformed the way SUD treatment is being provided, but at the same time has led to relapses, difficulties accessing treatment, increases in overdoses, and a host of new people struggling with addiction. We are also seeing that use of other substances rather than their primary drug of choice is occurring as well. Anxiety, grief, isolation, and financial worries, changes at home, and ongoing sense of uncertainty have all exacerbated this situation. I was reading a national analysis of 500,000 urine drug tests by Millennium Health showed an increase of 32% for non-prescribed fentanyl, 20% for methamphetamine, and 10% for cocaine from mid-March through May. During this time, the suspected drug overdoses increases by 8%. So again, we are here. There's some of the ways that the pandemic has impacted those dealing with the opioid use disorder. We are fortunate today to have 3 people on our panel that are experts in this field and are experiencing this in New York. So I would like to introduce the panelists, and I'm asking each panelist if you can come up with one word that encapsulates the impact of COVID, the pandemic on the opioid epidemic, please do. So I first would like to invite Dr. Taki. Dr. Taki, you're on mute.
Hi. Hi, everyone. It's a real pleasure to be here today and an honor. I'm Dr. Taki. I'm the medical director at Greenwich House MMTP, which is an opioid treatment program in Lower Manhattan. The word I would choose would be upheaval.
That's a very telling word. Next, I would like to ask Erica Naga to please take over.
Good morning, everyone. Thank you. It's my pleasure to be here. I am very fond of CBC, and I've been in awe of the work that they do. So I'm very happy to have been asked to participate. So the one word I would say, resilience. I am encouraged, although obviously concerned about the number of both fatal and non-fatal overdoses and concerns with access to care. I've also been encouraged by the numbers of clients that have continued to engage in care and are flexible and have adjusted rather quickly to the differences in access, which are vast, right? So
Yeah.
they've been able to quickly pivot. So resilience is what I come away with.
Very powerful word, definitely. Dr. Ramsey?
Good morning. I apologize. I have background noise. There are leaf blowing in my yard, so I'll put myself on mute when I'm not talking. The word I would use is innovation. And on the panel today, as I'm answering some of the questions, I'm going to be referencing both clinical experience, because I was still a clinical provider until early June of this year. So that was in a large FQHC providing MET in the community. And since then, I've transitioned to Oasis, so I'll be able to share some of that experience. Thanks.
That was wonderful. So each one of you picked very powerful words. So next I'd like to actually go to move on to some questions. So the first question is for all of you. Reflecting back on the outbreak in March, what immediate impact did COVID-19 have on the opioid epidemic treatment, and what was your agency's response? So I would like Dr. Taki to answer this first.
Sure. I would say that the immediate effect was just a major need for creative and flexible approaches to the pandemic and to our patients' needs during the crisis. That was reflected in, number one, a lot of take-home medication, specifically within our methadone maintained patients. For those of you who may or may not know how methadone maintenance worked before COVID, there was a lot of need for regular dosing in which the patients had to come physically to the clinic, particularly in the beginning of treatment. And when the crisis really took off, the federal government relaxed those requirements significantly. And that had the biggest impact on our patients' safety, on their trust of our system, and their retention and treatment, actually. So that was really kind of the biggest thing that impacted our patients and our staff. The other thing is obviously telehealth. It wasn't something that we had done prior, although we had been looking at it. It was a very, very quick transition to providing both telephonic services and traditional audiovisual telehealth services. The other thing that was really positive that came out of all of this was regular outreach. which hadn't really been done in the same way. So there was a very big push for the counselors and the medical staff to really initiate outreach to our patients weekly or more often even. And because we could do things via telehealth and by telephone, it really reduced those barriers to supporting our patients more frequently. And then I think rotating from home was sort of a new thing as well, trying to manage that staffing, having enough people in the clinic to meet the needs of the patients that were physically there, while still trying to keep staff from being exposed unnecessarily.
Absolutely. Telephonic definitely was able to re-engage and keep engagement.
Right.
So Dr. Ramsey, I would like you to answer.
Sure. So it was interesting because I actually took vacation between March 6th and March 14th. And as alluded to in the introduction to this session, that was sort of when upheaval occurred. And so before I left, I barely knew what COVID was, and every single email subject title in my phone while I was away that week was COVID, COVID, COVID. And so I came back to Sarah's word, upheaval. Fortunately, at the FQHC where I worked, we had already been utilizing telemedicine. However, in the more traditional format as Sarah described. So it was traditional audio visual using a patient in one clinic site, a provider in another clinic site. So it was not utilizing either the provider or the patient from home. So we were at least our patients were, bless you, our patients were familiar with telemedicine, not all of them, but a proportion of them, as were our providers. So we just had to quickly flex as far as changing platforms. I think initially for providers who were less familiar with it, there was a lot more audio telephonic only visits. Gradually over the coming weeks, we upticked with respect to doing video visits. I think overall, the fact that we were able to implement quickly the change, in other words, having patients not physically come to clinic. Initially, providers were coming to the clinic, but patients were staying at home until eventually all the providers were pulled home as well. But I think being able to respond to patients quickly, in other words, not putting them at risk of not getting their buprenorphine, for instance, when things were a little in flux initially, in other words, we didn't have our systems quite in place yet, or the patients weren't clear on what was going on, we just sent 30-day refills. In other words, if anything was in question, we sent 30-day refills just so that patients would not miss their buprenorphine. But quickly we were able to get the system in place. I think what was really interesting were patient responses. So, you know, we did not use urine toxicology at all. And it's still very, very, very limited urine toxicology even now, because again, patients should not be coming to clinic. So I think that was definitely new for patients. I think for them, it manifested our trust in them and putting their health and safety above things like markers of adherence to treatment, for instance.
Yes, and we'll definitely speak to that more as the questions move on in regards to toxicologies and also the relapse that's occurring because of that. So Dr. Ramsey, thank you very much. I do want to add till we go on for Erica. If anyone has any questions, we are going to, on the chat, you can put in through the chat for questions. And at the end, we will absolutely have a question and answer time. So by all means, please put your questions in there if you have any. So Erica, how would you like to?
Sure. I had also experienced was transitioning roles during sort of the height of the pandemic. So I'd come from another nonprofit social service environment into Chassis. And by then, in early May, they pretty much had systems established. I think one of the things that stands out for me in the early days and working in that other social service environment with clients with similar concerns and issues, was the trust factor, right? So our clients often have lots of reasons to mistrust, government, the communication that was coming from government, which at times was inconsistent. So it was becoming the trusted messenger for clients and helping them to, develop, healthy habits in terms of, distancing and mask wearing, and which initially early on there, mask wearing wasn't even promoted. So I have to say though, Chassis coming into their system in May, I think they were really uniquely positioned to not only pivot more seamlessly to virtual, telephonic, and some in-person engagement, but there was also a lot of community work. So our MAT nurse would go into the community to meet with clients who continue to struggle, which was very helpful. So I think one-stop shopping was key here at Chassis, and while many of our sites were closed, our 24-hour Next Step Resource and Recovery Center and the pantry remained open. So we began to, we created one-stop shopping. So Next Step in Recovery, you can get pantry, you can get syringes, testing, and support, recovery support. And the pantry, we were able to, while reducing the numbers of staff, we made sure that there were key staff in place in those locations. So at the pantry, your syringe exchange person was, able to, offer folks food and syringes, and that was really critical. So I was very proud to join this team and work with the extremely committed workforce here that really met clients where they were.
No, that's definitely, and the clients needed that. So as Dr. Ramsey put in the chat, someone actually threw a question in there in regards to accessibility with our phones if the client didn't have a phone. We're absolutely wonderful question, and that was on one of our questions to ask today. So the next question that I would like for Dr. Ramsey and Erica to answer. Looking at your agency's data, what trends in opioid use, treatment, and overdoses have you seen in New York City since the outbreak of the pandemic? So I would like Dr. Ramsey to answer that first, please.
Sure. So with my OASIS hat on, I can give you a little bit of data from what we know thus far. First of all, with respect to overdoses, I think it's really important that we use caution when we're talking about the increase in overdoses because we do not have definitive data yet. So there are anecdotal reports of increases in overdoses, both from counties within New York State, but then also across the country. The AMA actually put out a bulletin maybe about a month and a half ago or 2 months ago that 34 states had reported increases in overdoses. But again, I just want to clarify that because definitive data on overdoses relies upon medical examiner reports, toxicology reports. It is not based on OD map or ED visits for overdoses or police reports on overdoses or anything else. So that data lags behind real time by at least 6 months. And in the context of COVID-19, with the pressure on MEs to do COVID-19 autopsies and many other needs, that data is probably going to be pushed back even farther. So while we can talk about a likely increase in overdoses, we just have to qualify it until we actually have real data. With respect to other services, what I would say from putting my clinical hat back on when I was at the other agency until June, what I would say is we had a huge influx of patients during COVID-19 for the treatment of opioid use disorder. And I think the loosening of federal regulations allowing for initial visits for buprenorphine to be done not only by telemedicine, but also by telephonic audio-only visits, which had not existed before COVID-19, that allowed much easier access for patients to actually start on treatment. So whether patients just felt ready at that moment in time or unable to access their normal drug supply or for whatever reason prompted them to seek treatment at that moment in time, they were able to get in a far easier manner than typically. And then going back with my OASIS hat, if we talk about looking at telemedicine data, looking at, for example, Medicaid claims, there's a huge increase, for example, between April 2019 and April 2020 by many thousands. So last April, I believe the visits for telemed were less than 250 in the substance use disorder treatment system, and that number was up in the 20,000s visits. So huge increase. And I'm going to put myself on mute because they're close to my window.
Thank you very much. So Erica, adding on to what Dr. Ramsey was speaking, in your agency, what data have you extrapolated in regards to treatment that you've seen with your clients in regards to the pandemic and any trends within the opioid use?
Yes, certainly. So the number of clients receiving counseling services overall, so when I talk about sort of this continuum of care, I'm speaking of the harm reduction, counseling, sort of all low threshold, but sort of the gatekeeper to syringe exchange, syringe access, and MAT. Our program is affectionately referred to as the BUTE program. Those counseling sessions, we did see a significant drop in those type of sessions. A huge increase, however, in the number of people enrolled, and an impressive retention rate. So we have really been able to retain clients and maintain an impressive level of engagement. You know, as we've talked about, as Dr. Ramsey, you know, shared, telephonic, and virtual. So and speaking to the harm reduction team, one of the things that they now want to permanently implement are virtual Narcan trainings. That the participation in those trainings, you know, has tripled in some cases, and they, you know, based on the anonymity. So that it gives people an opportunity to participate even anonymously. You don't have to share your name or your picture. So families, folks in the, you know, supporting addiction, folks with OUD in their families and community, gives them an opportunity to participate. Sadly, the numbers of reported overdoses and you know, again, not confirmed whether they're death or for the fatal cases is, you know, related to the overdose, but the OUD use, but certainly the number of reports that we receive, hospitalizations related to, or ER visits related to overdose, we've seen almost a 70% increase in those. We had one person during this time. We looked, you know, year to year, but we also zeroed in 2019 and 2020. And during that period, we had, in our BUTE program specifically, one fatality, and this year we have two. So 100% increase, but relatively low numbers. And I do think that is, you know, based on the type of engagement that we have with clients, and the low threshold, you know, multiple points of access.
Absolutely.
We find very helpful.
Absolutely. So,
Carolyn, do you mind if I just make one more point just off of something?
Absolutely, jump in.
So another thing I think to keep in mind is that going from 2017 to 2018, for the first time, we saw a decrease in overdoses, both total overdoses and opioid overdoses. But the preliminary CDC data for 2019, which I know it's a year later, but it is still preliminary data, showed that there was an increase in overdoses, both in total overdoses and in opioid overdoses. So that was going on before COVID-19. So again, we don't know what our outcome is going to look like for 2020. And then with respect to New York State, and this is based on CDC data, this is not based on either New York City data or New York State Department of Health data, but this is CDC data for New York State. There was actually a decrease in total overdoses and a decrease in opioid overdoses in rest of state outside of New York City, but an increase in total overdoses and opioid overdoses in New York City in 2019. And again, that's CDC data, it's not New York City or DOH data.
I mean, we definitely know that the epidemic was very present, although, you know, innovation and treatment, one of the words that you used, definitely was assisting in that epidemic. But with the pandemic, as we said, caused more areas to rise with other situations happening and problematic areas. So going on to the next question, as treatment providers, we responded to the patients, right? We responded to also our staff that we work with. So this is like a two-part question. The first part is when the patients were hesitant to seek their substance use disorder treatment on site in the early days, because as you know, in the beginning of March, we were, trying to do a hybrid model. There wasn't a full closure yet. So when you first look at the hybrid model of the clients that were solely on telehealth and trying to do that conversion, very rapid transition, March 16th, I feel, was the magic day, and everything started, as you said, you were on vacation, all those emails were coming through. We all know as treatment providers, those emails were inundated every day, new guidance, and it was because we were trying to keep up with all of the information that was coming from CDC and DOH. So I would love for Erica, Dr. Ramsey, to please expand on what you were speaking about with that rapid conversion when that was happening with our clients.
Yeah,
yeah. Go first.
Sure. I think initially we were, focused. It was a crisis management, right? A crisis response. We certainly weren't envisioned 6, 7, 8 months of
right.
isolation and developing sort of new normals for engaging clients in treatment. So we were very focused on, preservation. Early on, it was, okay, let's create these sort of workforces that can, switch on and off, like, sort of preservation of manpower. And so we were very much, while limiting, and so, in effect, limiting contact, a number of people on our sites, but very focused on crisis management. How do we, get our clients enough medication, minimal engagement. There, certainly no innovative treatment, at that point. So very early on, and really adjusting to the guidance. And as I said early, our clients were, as we know, very suspicious of the guidance and what do we do? Is this meant to, further fragment us or keep us, disconnect us from the services that we need in the communities that we live in? So there was definitely concern around just that, even outside of treatment, our clients' ability to stay safe. So I think, again, I want to go back to when I entered Chassis and the staff, the team here, just because they saw the need, created a brand new program, delivery, home delivery of food, just to keep our vulnerable clients indoors as much as possible. So and that was, completely driven by the staff's interest in maintaining safety. It was, we had board members volunteering. We had community members, the families of staff volunteering to do those deliveries. So, when you work in that, and you're in that type of environment, and that's very also much about, work in Staten Island. It's a small town, the community here. We're all once or twice removed from each other. So I would say that, it was dealing with the all of the messages coming, really creating some ability to manage the critical needs of clients. That was the focus early on.
Okay, thank you, Erica. So Dr. Ramsey, in response to that question on the first part of the rapid transition with your clients and the ones that were very hesitant coming on site, how did you as a treatment provider prepare for that?
So you have the magic day is March 16th, and I agree with you, that was sort of a pivot point, but it wasn't until March 23rd that my organization actually said, stay home, don't have patients come in. Okay. But as a medical director of a program and feeling like our patients were vulnerable, and the comorbidity with mental health among our MAT clients is about 80% in our MAT program at the FQHC. So I made the decision that if a patient felt uncomfortable, then they shouldn't come in. And that was the vast majority of our patients. A couple patients still came in during that week of March 16th, but the vast majority, given the option to not come in, chose not to come in. And basically that was it. Nobody came in after that point. So I think Nora Jacobs has asked her question twice, so I feel like I just will address it a little bit, even though I know we're getting to the accessibility question in a little bit. But I think that if we couldn't reach patients, so either their phone was turned off or they didn't have a working phone, we just sent the scripts because we figured if worse came to worse and they didn't contact us, they would go to the pharmacy to see if they had a script waiting for them. So if we couldn't reach people, that's what we did. We sent scripts for 30 days. For non-controlled substances, we sent any refills for 90 days so that people didn't have to go to the pharmacy more than they needed to. And then we sent, if people didn't have access because we didn't know what was going on with the local syringe exchange program, then we just wrote prescriptions for needles and syringes. And we wrote naloxone, for example, with 11 refills or 25 refills or whatever, so that we knew that they would have access to those services that they would normally get coming into clinic with us. So those are some of the things that we did. And I think that every day new information was coming, whether it was CDC information, DOH information, internal organizational information, or we were not under specifically regulatory guidance. Sarah could address that because she had to respond all the time to regulatory guidance, but things were changing every day. And I remember when it became knowledgeable to us that that the DEA had lifted the initial visit for buprenorphine being in person, which I think was on March 30th or around that time. That was enormous. And like disseminating that information immediately out to our network was imperative to get people linked.
Okay, so I'm actually going to pause on my second part of that question because I think I can add on to what Dr. Ramsey says, and Dr. Taki, we can expand a little bit more in regards to the telehealth, since we already started that discussion. Mm-hmm. So as you stated, you know, in New York City, we have a large array of different population of clients, some with the availability and the accessibility to have internet, telephone, and stuff like that. We've mentioned our shelter clients, we've mentioned clients that don't have that capability. So with everyone pretty much shutting down, as we want to call it, you know, the quick shutdown, and everything was very rapid, and trying to engage clients and have them understand the information and not exasperate, obviously, anxieties and stuff and depression. The telemedicine with the federal guidance coming through, and with Medicaid, now that we talked about, Dr. Ramsey, you're talking about the claims, having that accessibility to use technology, there's positive and negatives that came with that. One positive is obviously the quick response and being able to be readily available to our clients, and to be able to add on to engagement calls and the allowance of different types of billing aspects, you know, that we can, you know, enhance. There was those clients that did not have the capability to have the use of a phone. It was wonderful when HRA allowed the minutes on those phones to not be, you know, stopped. What did your agencies do to those clients, that select cohort that did not have the accessibility for that? And we also should add on individuals that are scared of using the phone. As George says, the mental health aspect of this that happened. So I think this is important for all of us to answer. So I would love to hear, you know, Dr. Taki, I would love to hear how you handle that.
Yeah, it's definitely something that challenged our organization, because we do have a significant number of patients who do not have regular access to a telephone or audiovisual capacity. One of the differences about an OTP, specifically for patients taking methadone, is they have to come to clinic at least once a month. Like, there was no option to refill it at a pharmacy. So what I was really proud of from our organizational approach to this was we instituted telemedicine within our clinic. So the patients would sit either at a telephone, or they would sit at a camera in one room, and the practitioner would be in another room. And if we had to go and either examine the patient, or for admissions, we still had to see the patient in person, we would go in with PPE on once it was available, but the majority of the session would be done remotely, even with the patient on site. And that really, I think, helped patients without access feel comfortable sitting, because that was another part of it. Even if we were seeing people in person, the patients would be anxious about sitting long enough to do a good evaluation, to adjust their dose. But with the actual physical separation, I think both the counseling improved because the staff wasn't so anxious about physically being next to a patient, and the patients without access felt a little more comfortable sitting long enough with a staff member to really allow us to address their needs. So that was one way we addressed it. Other obvious ways were, for example, if a patient was in a nursing home, a nurse would allow them to use their phone, or a family member or friend that may live next door would try to help them with access. We tried a little bit with shelters to work with their technology, although that was less successful. But we were as creative as we could be with the access.
Thank you. I appreciate that. Erica, would you like to answer how your agency dealt with that cohort that did not have the accessibility?
Yeah, sure. Right. So yes, it is a reality that many of our clients won't have access for the entire month, perhaps. But most people either have limited access during the month or access through the community itself, their family members. So that was very helpful. That was something, I think, again, that's where I saw the resilience in that. We were often, while we wouldn't share information, but we were often connected to a client through another client who knew that this person, did not have access or was in crisis. But we also, I think what was critical, because the BUTE program did operate, really, I want to say 100% remote, but no, we did have the occasions where the RN would go into the community to meet with clients in crisis. But the model was really meant to, to have that exchange telephonically or virtual through Zoom or FaceTime, and then submit the prescription. The critical component was the fact that as I mentioned before, the Next Step Recovery Center remained open, as well as the pantry. So those clients could reach us. They would, they had access to services, they had access to staff. And so I think that was very necessary for a number of clients.
Absolutely. Dr. Ramsey, do you have anything that you'd like to add on that was different and innovative?
Yeah, I would echo that both the strategies that Sarah and Erica mentioned are strategies that were used by my organization. In addition to that, I would say that there are some patients that I knew just needed to physically come in. That was the only way that they were going to see me. I'm thinking in particular, I had an HIV. She didn't see me actually for substance use disorder. She saw me for her HIV and her primary care. And she's 75 years old. She does not know, she does have a smartphone, but she doesn't know how to use her smartphone. And she doesn't answer her phone. If you call her on the phone, she just never answers it. So it was necessary for her to come in to see me, not only so she could have that face-to-face that she really wanted with me, but I just think for her, getting care over the telephone or on a video just didn't work for her.
Right.
From a sociocultural perspective. There were some of my patients, particularly I have one patient who is marginally homeless. So he's living temporarily in a hotel. So he's really homeless, but he's been in the hotel for a long time. He never answers his phone as well. So it was impossible to get him to actually have a video chat with me, but he likes to just come in. He just likes to stop in when he needs something. And so he just would stop in. And if I weren't there, then they would set a time with him where he could either come back and see me, because I was going into the clinic once a week physically, or that we could set up a time for a chat when he actually would answer his phone. So there were kind of a variety of strategies that we did that. But one thing I did want to mention, which I think also addresses the accessibility issue, is that my organization put an emphasis on trying to get 100% video visits, which I don't think is realistic. I think that I think for depending on your patient population, you may be able to get a majority of video visits. But again, that depends on how tech savvy your patient population is. It depends on broadband access. It depends on minutes. It depends on so many things, comfort level, privacy issues, whatever. So that I felt like that can create a double standard, and that could actually increase inequities if you try to make that duality. Because if you're saying if they can't do video, they have to come in physically for a visit, that's creating a duality that shouldn't exist, of putting patients without a phone, a video capability at higher risk than other patients. So I think it's really important that we continue to fight for parity on reimbursement issues, because all our patients don't have equal accessibility to resources.
I agree, and I would like to add on. So for our agency at Samaritan Daytop Village, we have an ACT team that is in the shelters, and we also obviously have substance use disorder clinics. What we did was there was a small cohort that did not have access to a phone. So I want to say we piloted, and it actually was working pretty well. We bought those prepaid minute phones, and we looked at our budgets. Like Dr. Ramsey, you said, for reimbursement, we spoke to OASIS and OMH to see, how we can make this work. And I was hesitant, I will self-disclose, I was hesitant, would they lose the phone, would they this? It has been working very well, where they get the pre-minutes, and they were able to use their phone sessions, and we were able to continue the continuity for their treatment. So as we all did during this time, we all came up with our own innovation, which was good. So I'd like to move on to the next question, and I'm very happy to see that there's questions that are coming in on the side of the chat, and I will definitely be addressing those. So to go back to the second part, since we talked about and we touched upon the clients that we're working with, we had staff and staff from the medical side to the clinical side to the administrative side, all were feeling a certain way of anxiety and concerns in regards to the pandemic. And since we mentioned that there was different information, I would like to say, on a daily basis coming through the news, through social media, which we know everyone reacts to, and to also our own guidance that our agencies were sending out. I would love to know how your agencies manage the concerns of their staff during the COVID-19, moving from hybrid model to a closed model to crisis, as Dr. Taka, you said, clients coming in that they have to come in regardless. So Dr. Taka, would you like to take this one first?
Yeah, sure. This is an obvious sort of a struggle and challenge that we're continuing to deal with. I do want to say, however, before I start going into the anxieties, that we also had a lot of resilience, and a lot of staff just sort of soldiered on. This is what we came into the field to do. There wasn't, a significant number just came to work, and there's sort of an acceptance that there's inherent risk when you're in the healthcare field. So I do want to start with that. But we did have anxieties, and I think our approach, number one, was just constant communication. During the peak of the crisis, I think we had daily staff meetings. It was every morning a huddle to talk about what's changed. As a medical sort of provider, I would talk briefly about what we know and what's happening in terms of the knowledge around COVID. And then as the procedures changed, we had to review that with all of the staff. So I think that the communication was really essential. We also had transparency, I think, with our staff in terms of we don't have a certain number of masks, and this is how we're going to work around that until we get PPE. These are the things that we're working on. For example, the plexiglass at the front, we're working on it. It's in the works. We'll use some plastic barrier in the meantime, so that staff didn't feel like they were in the dark around the progress with the crisis. Then we do have some very high risk staff members, and that was identified very early, and we did everything we could for people in that high risk category to keep them at home. And I think that helped, at least with their level of anxiety and willingness to continue working. And then supervision and support individually within the organization. So having those conversations directly with staff members and also with, outside of it. So what are the resources within like the union, within other behavioral health settings, with the Department of Health in terms of counseling and support. So those are probably the main ways that we try to reduce some of the anxiety and give people a sense of comfort and security.
Thank you. Dr. Ramsey, would you like to add anything to what Dr. Taki was saying?
Sure. I'm going to talk about how I addressed it with my team. So my team consisted of 10 teams across a geographically large area. So some in Suffolk County and then throughout the Hudson Valley. And I think I was gone that pivotal week. And so when I came back, the first thing that sort of my other team leaders said to me is, you need to meet with the whole team and exude calm because nobody's calm. So I feel like that was my main role, was sort of, as Sarah said, filtering information to make it understandable to all the staff and trying to exude calm and confidence as much as I could, but yet inform them as information changed. I remember somebody asking me about masks on March 16th, and on March 16th, there was no recommendation to wear masks. And so I said, there's no recommendation to wear masks. We don't think it does anything to protect you. And yet, 2 weeks, 3 weeks later, it was wear masks. So you had to be flexible with all the new information that was coming forth daily. And I think by being able to dissect it and filter it to the staff, and I sent email blasts constantly with updates of clinical information. And then ultimately just having them remember flexibility with patients, And then our staff went home, I think, third week, and has been remote basically up until I left in early June. They were still remote. And so supporting staff, actually 2 of the staff in my own facility one lost a grandmother and one lost her mother. And so supporting staff through their own struggles and losses due to COVID. It was interesting because I remember this was fairly early on because I was still seeing her in person. So this probably was someone who didn't get a message that we weren't seeing patients in person and showed up in early April. And she thought COVID was a hoax. And without breaching my staff's confidentiality, I had to say, actually, my staff have lost family members. And it was really interesting to see it almost turn into then, oh, it is real? Like, yeah, it is real. Those are kind of some of the strategies that we used.
That's wonderful. So we've been talking about strategies, interventions, and I'm going to use, Dr. Ramsey, your word innovation, because that was actually a key word that had in the next question. And I think we can actually add on, Megan put in a question in the chat, and we can add, that question to the next. So obviously, because of the pandemic, we, state and federal, and also us as treatment providers, got very innovative. And Dr. Ramsey, there was a really poignant word that you used. And during this pandemic, we had to get innovating with treatment, with the addiction treatment and mental health and treatment aspect of it. And also what Megan was asking in the chat was, with the innovation, did you collaborate with other providers and other agencies to help you during the pandemic? So I guess the question I'm trying to get to is, what is the best way, as Megan is asking, the best way to show this type of collaboration that you did with other providers, if you did? And also, what innovation addiction treatment that you were able to put through your agencies for your clients, and also, your staff being comfortable with the changes of now doing telehealth, normally doing psychotherapy or groups and individuals on a face-to-face basis, and now having to actually engage a client via Zoom or even telephonically, right? So that took a lot of supervision and training, and I'm sure innovation. So I would love to hear what you guys have put to that. So Dr. Taki, would you like to take that?
Yeah, sure. I think that's a wonderful question, because it was such a time of upheaval, and there, particularly in the OTP setting, like a very kind of rigid, structured history to it and an approach, and that all very quickly just evaporated. And I think that individual clinics and individual providers were almost needed the support of each other to understand kind of what's too far, what's reasonable, what's kind of happening in the field. And probably the most helpful thing was Oasis had office hours regularly during the height of the crisis. And during those office hours, medical directors would basically, it was facilitated, and a lot of the questions we had would be discussed around outdoor dosing of medication, which was sort of unthinkable before. The idea of the increased take-home medication. It really, when we had that community in that space for not only reinforcement from Oasis, but also from each other, that this is sort of an okay thing to do right now and an indicated thing to do, it allowed us to make those changes a little more uniformly across the field, and also within our own agency feel like we're not going so far out of the norm where we're kind of putting ourselves in a bad position. So that was helpful. And then just on a local basis and more sort of informally, I know that a number, probably 7 of my colleagues that I knew from either previously working or just knew from being in the field, we started doing Zoom meetings weekly to sort of ask like, hey, what are you guys doing? How are you addressing this? My favorite moment in the pandemic, I think, was one of the medical directors that I knew peripherally, but we weren't good friends. He called me on a Saturday and was like, there's some masks in Chinatown. Do you want any? And he bought me masks, and I went over there and like picked them up. And that kind of collaboration and just looking out for each other was really beautiful and kind of new. We really operated in silos before. So I think those were, so the formal engagement across the field, but also just the informal working locally with your friends and colleagues was really helpful.
I absolutely agree. Zoom has definitely broadened us to be able to collaborate. And I want to say the conference calls.
Yeah.
So Erica, would you like to add on to that?
Sure. I'm thinking of the support that CHAFU received, for instance, from the borough president's office. I think they're very the folks that you would hope to receive support from during the pandemic, and some of the funders. The biggest, I think the most support we received in terms of PPE, which was extremely difficult to access for everyone at the height of this, came from those formal systems, and we are extremely grateful for that. Outside of sort of the BUP and OUD work, Food Bank has been enormously helpful. And that, again, because we sort of converted to a one-stop shopping, it was very critical. Our ability to address food insecurity really, again, supported our ability to remain connected to clients and ensure that they, knew that we were here and at least had access to us for food. Again, the engagement was not limited to food. So Food Bank was enormously helpful to us during this pandemic. We received everything from tractor trailers to funding to purchase more food. I think in the OUD area, the collaboration was more internal, and that everyone really worked to support the clients who were in the most crisis in the agency. Again, I referenced the new food delivery program. Sort of everyone became an expert in crisis management.
Absolutely. So, Dr. Ramsey, in regard to innovation and addiction treatment, what have you seen through the agency that you were at, and also if you want to collaborate, add on to Oasis, that you feel you've observed during this time?
Sure. So I'll actually talk more about from my position currently. So I think that a lot of the innovation, while it did come from, say, OMH and Oasis, who have been extraordinarily collaborative during this time, obviously in creating guidance and infection control and doing that in conjunction with the DOH. But just sort of loosening of restrictions and things like bundling payments and adding payments, making sure that telephonic is reimbursable, including for peer visits, things like that, peer services, is all really important. But I think something important to remember is that a lot of the sort of regulatory flexibility comes at the federal level. It is not at the state level. So OASIS is not in control of that. So we're getting messages of, you know, are you going to keep the regulations loose? And most of them we don't have anything to do with. So I think it's really important if you're thinking about what's going to happen post-COVID, that you go to the resources that really make those decisions, and that would be the DEA and SAMHSA. Regarding both OTP flexibility with regard to take-home bottles, as well as buprenorphine initial visit flexibility. And certainly OASIS supports all of that innovation and all of that flexibility, including when the pandemic is over. But ultimately, it's the federal government that's going to be making the decision on that.
Absolutely. Well, thank you. So to move on to our next question, as you guys have, pretty much everyone has touched on this a little bit, I wanted to just get more broad on it. Access to medication-assisted treatment, that was a really big conversation piece, and also with the regulations that came through, drove waivers with the telehealth to make sure our clients had that accessibility, because, you know, the unknown of what happens with the client, you know, obviously during this time, and we talked about anxieties and stuff like that. So can you speak specifically to the changes that occurred in the accessibility to medication-assisted treatment? What surprised you in terms of those changes? But also, I would love to hear about when we talk about induction and maintenance with medication-assisted treatment, because as a treatment provider, I don't know if your agency saw this, but our doctors normally having a visual face-to-face during induction, and a team working with that client during that process with ancillary withdrawal with the client, now being able to have the accessibility of a telephonic or the telehealth, you know, was apprehensive, right? It's a new technique that's being done, and us as leaders have to explain that to our treatment providers. So I would love for you to expand more about those areas of the telephonic and video accessibility to the changes, how your agency moved on with that and was able to expand. So Dr. Taki.
Sure. I think Greenwich House already has really embraced harm reduction as part of the continuum of what we do, particularly with methadone. So when the pandemic hit, there was this need to kind of understand the risk of overdose from having too much methadone or diverting the methadone with the risk of COVID. And recognizing that that balance had significantly changed to the side of COVID being the greater risk. So I think that constant conversation was had over and over and over again, to think of it in terms of health and not in terms of just drug treatment. Like the overall keeping a patient that's high risk at home, able to social distance, and the likelihood that there would be more harm done if we brought them in, right? If we continued to do things the way we'd always done them. So that was probably the number one thing. One thing I wanted to touch on that was a surprise to us was when we started to give a ton of medication as, you know, a way to reduce the risk of COVID. A lot of patients thought we were closing. Like just were like, you guys, are you going to shut down? Why are we getting all this medication? And then for the new intakes, people that really needed treatment, they also had the impression that all of behavioral health had shifted to telemedicine and nobody was seeing anyone in person. And methadone in particular didn't have that waiver. So we still had to see a patient in person. So some of the things that we did were to very specifically advertise on our website. Like, we are open every day, every day. You can be admitted, really reinforcing that with the patients so that they came back. Like, we're an essential service. We're not going away. yeah, that was something I just wanted to mention. That was surprising. Like we had to put stuff on social media to really advertise that we were still opening, open. So it was sort of on both sides, understanding like this is why we're giving the medication, this is why we're still here, and then for the providers, again, not locally. I think our clinic got it right away because of our orientation around viewing opioid use disorder. But when we did, it was really talking about it in terms of relative risk.
Thank you. Erica, would you like to expand on how your agency dealt with the?
Sure. I think more operationally, well, I guess that's what I'm present to. Every day I learn something new about Zoom. We spent a lot of time learning about Zoom. We spent a lot of time exploring virtual platforms and trying to educate our clients, our workforce. So yeah, I think the challenges is just as much as our operational, the typical bandwidth issues, operational issues, as it was sort of apprehension. And again, really being clear, as Dr. Ramsey mentioned and Dr. Taki has talked about, what is the priority? Keeping clients safe, but also leaving, being creative enough that we recognize that this can't be cookie cutter, right? We have to, make sure that there are enough varied approaches to engagement and access to services that clients can choose, and we can make that assessment based on their needs. So while, again, I've said many times, while many offices were closed, we did really be sure to campaign and publicize the fact that we were open for business, we were open to on-site engagement, community engagement, telephonic, and virtual engagement. But it was, I think those initially, the operational pieces were, interesting, I'll say, in terms of making that transition.
Absolutely. So Dr. Ramsey, I'm going to be able to actually, I would love to hear what you have to say in regards to the process of the changes. And this is also, I can piggyback off of Dr. Trigg put in about a question in regards to the pandemic and the COVID regulations. So with the changes that we saw with medication-assisted treatment, not just what surprised you with your agency and how you were able to, address inductions and address the medication management, I would love to hear what you think should really sustain. What as a treatment provider would love to see for medication-assisted treatment to be able to stay with these new regulations that could actually assist us as treatment providers with this new innovation and also our clients, because if it wasn't for the pandemic, the accessibility that these regs have allowed, and we all see that, even clients who are just hesitant to come in or don't handle their scheduling properly, or very in a very impulsive manner coming in for help, and if we don't grab them at that moment, then we lose them. And being able to do telephonic and not having a doctor on site and able to have a doctor call in was a really big help as the agency. So if you can expand on that, and then I'd love to hear more about that.
Sure. So the first thing that I would talk about, you asked specifically about how it affected induction and maintenance with respect to buprenorphine. So with respect to buprenorphine, it really didn't change anything because we don't do any office inductions. Everything has always been 100% home induction. The reality is probably 90% of the patients who walk in the door at an outpatient, FQHC, like primary care setting, like I had practiced in, have buprenorphine experience. So whether that was buprenorphine that they were using on the street, either to self-manage their own opioid use disorder or to treat withdrawal, or they had gotten it in detox or rehab or from another provider previously, or however they had tried it, most people are experienced with buprenorphine. So it's really not a big lift to have them not have an in-person visit, because that's something that is very little of our time spent talking about induction unless somebody has had precipitated withdrawal in the past, or they're actually buprenorphine naive, which, as I said, is pretty rare. these days. So it didn't change much, and it actually made access, we already had same-day access, but literally somebody could call, and you could, if a provider anywhere in our system was available at that moment in time, they could have that call with them right then and there. The other thing that was great about accessibility with respect to the visits, whether telephonic audio or video visits, was that we had a low no-show rate for our MHE program anyway, but it went basically to 0, because if a person were on my schedule at 9 o'clock and I didn't reach them at 9 o'clock, I would try them at 10, 11, 12, 1, 2, 3, 4 until I got them. Or they would call back or they would text, you could text through the platform. They would text me that they were ready for me or that they were in my waiting room. And so there was so much flexibility as to when and how you saw a patient. So that's some of my experience clinically. And then going back to the regulatory questions, I'm going to kind of reiterate what I said before. I think we would like all of these regulations to remain loosened. So for telephonic initial visits for buprenorphine, all the video visit freedom, including for OTPs, except for the initial visit, as well as the loosened take-homes, et cetera. But again, those are all federal regulations. And so my organization doesn't have a lot to do with that, other than supporting them.
Right, but your agency can listen to the treatment providers speaking about program regulations that they have.
Sure,
right?
sure. And OASIS agrees with all the loosened regulations.
Yeah, the loosened definitely does assist. And hopefully with those new regulations coming out soon, they'll have that loosening in there for us. So just to now add on a reality question that we're all facing and is happening in the news every day is, quote, they saying a second wave, right? So we're hearing this terminology, a second wave, and our agencies are preparing for what the second wave is going to look like. And so in the, our substance use disorder field, a second wave coming about, is there anything that you all can speak about what you would do different than what originally happened? So I know we're trying to prepare what is there anything that you would do differently? Erica, do you want to take this?
I was thinking and thinking about your question. I said, well, we're in a different place. I think part of the challenge early on was that this was new for everyone, right? Unprecedented, and the guidance was well, quite regular, often different. So I struggle to identify what we would do differently, because yes, there were some missteps, but it was a sort of a collective misstep. And, certainly we did work very hard to follow the guidance. I think we've learned, to stockpile supplies more than we would typically. We were, often lean and had, felt very secure in our ability to get supplies when needed. So right. I think there are certainly lessons learned there. I do know, though, that we weren't necessarily prepared. We do collect a lot more email information, alternative contact information for our clients. We definitely stress that more than we did pre-pandemic. So I think, and so I've arrived there. So I think more discussions and, sort of preparing our clients for either isolation or limited, contact with providers. I think those are very useful discussions and help out, prepare our clients and really, what will that look like? What's your plan for food, for supplies, for medication, other types of medication?
I agree. So absolutely what you mentioned in regards to planning and the contact information for our clients, definitely updating and stuff. So I just want to ask Dr. Taghi to expand. We have about 5 minutes left. So I want to just hear what, if there's anything that you would do differently.
Well, obviously the PPE supply is part of what keeps us up at night. And we have started to see people in person more, not at the level we were, but there are some people that just cannot manage, or they just do better with the structure of the methadone program and coming more frequently. So knowing when to pull back on that again and how quickly is something we think a lot about. But one thing that was structurally implemented that we did not have in the beginning of the pandemic that is such a huge tool is a delivery system for the methadone. And that was a joint project. I know it was an enormous project with Oasis and the Department of Health. But now we're in a position where we could put a lot of patients on delivery if there is a very severe second wave. Right now we have about, I think, 25 that regularly get the delivery, but the ability to upscale that and have experience with it already, I think is a huge benefit and something that we'll really kind of keep an eye on if it continues to be in place. The intervention in terms of observed dosing is really a telemedicine visit. So we can keep the patient entirely at home, and then once a month or once a week or however many times we feel it's necessary, get the patient on audiovisual and watch them take their medication if we have concerns about them not taking it as it should be. The other things are flu shots. We're trying to make sure we have enough for our patients. And yeah, I think that's mostly it, being ready to really talk about the fears that patients have, because the COVID fears were a big part of the medical visits. What should I do? Should I be leaving, wearing masks and things like that? What are the symptoms? And then with the therapy visits, obviously managing that anxiety, the increase in isolation and depression. So just being ready to upscale that, I guess.
Okay, that's wonderful. So before we get to the question section, there's a couple of questions that we're going to throw out there. I want to wrap up the 3 words that you guys said, and which was amazing was, Dr. Taka, you said upheaval, and Erica, you said resilience, and Dr. Ramsey, you said innovation. So those 3 powerful words, I believe you were able to actually integrate them into your conversations, and it was really telling that as treatment providers, we all, collectively got together, collaborated with each other, and with the assistance of state and federal, was able to actually help our clients. And that is pretty amazing and pretty special. So our clients are very lucky to have all of us, to work with. And so I thought when we get to the question section, there was a couple of questions that I wanted to actually expand upon, if we could do that. I'm going to go to them. Okay, so one question was from Bianca, and what she wanted to know was, what she's looking for is tying up. The research has shown, she says, to an even distribution of buprenorphine versus methadone in New York City across social areas. Methadone positively correlated with poverty and zip codes, predominated by Black Hispanic residents, buprenorphine concentrated in areas with highest income and highest percentages of white residents. Can you repeat that? Okay. So what she's looking for is what she's, I have a timer on this. Her question is, how have the changes in service delivery brought about by COVID-19, telehealth, regulations, et cetera, positively or negatively impacted this disparity? And Dr. Ramsey, would you like to take that first?
Sure. So I think in both positively and negatively. So positively, in other words, how it helped sort of limit the disparity by providing more equal access, more so whether that's by the methadone delivery system or whether that's by again, telephonic audio only visits. And again, yes, not everyone has a phone, but having telephonic audio visits be an option includes more people than having just in-person visits. Obviously, COVID and everything going on right now regarding racial justice and social justice has laid bare gross disparities within our society that are endemic and that are fostered by structures in our society. And I think we are only at the tip of the iceberg of scratching that. There for sure is inequity in the substance use disorder treatment system. There is racism throughout the history of drug use and drug policy in this country. And none of that is going to go away anytime soon. But I think the looser the regulations are around all forms of treatment for substance use disorder, that'll begin to address some of those issues.
Thank you. Dr. Taki?
Sure. Again, I think it had positive and, just as Kelly said, positive and negative effects. My first thought is around specifically telephonic sessions. The fact that those were also reimbursed allowed people that may not have funds or the access to audiovisual and internet capabilities to continue to get counseling, medication visits, things like that. So I think that had a positive effect. The fact that some people don't have even telephonic services, I think, exacerbated that risk, because then they had to come in physically to have those services done. And then, one thing I saw clinically, we all know that in Latinx and Black communities, there have been higher mortality rates. I certainly saw with my patients sometimes a significantly increased level of fear and just even leaving their house, like at all. So delivery of the medication and then the increased take-home bottles really, I think, reduced a lot of, maybe not a lot, but some of the disparities. And if it were to go back to the way it was, I think we would see more people dropping out of treatment because the fear of the infection is greater than their fear of, the opioid use disorder killing them or making them sick. And then virtual buprenorphine. It changes it from, neighborhood and penetration of programs to just, you can get on the phone or on AV and be able to get treatment with buprenorphine.
Thank you very much. And Erica, what have you seen that's positive and negatively impacted with this disparity?
Well, fortunate, Chassis has the only grant-funded, unlicensed MAT program in Staten Island. And I think, and it's on the North Shore and in a neighborhood where it's critically needed. And unfortunately, this program is the largest, we've been told it's one of the larger programs in the grant, in that portfolio. And we've had to close intake. We just don't have the bandwidth to meet the demand. I did mention that there was a decline in enrollment, but it's still, we still enrolled 18 new clients during the height of the pandemic between March and June. Okay. So we need more of those programs, because it's not just the nurse practitioner or MD prescribing, it's the peer support, it's the trusted messengers, it's in receiving the care in the community where I live. I'm not going to a doctor's office and having an exchange with a receptionist and the doctor. I have time to sit with a nurse who really, I'm a social worker, and she said, I told her, you have social work in your blood, and who is very interested in everything, and holistic approach to treatment. So I think that's what's needed, and I'm happy to be a part of a program that strives for some balance.
Perfect. So I have one last question that is for you, Dr. Ramsey, specifically. And before I ask the question, Caroline wanted to say thank you to everyone for your high quality discussion. So the question to Dr. Ramsey is, can you please speak specifically as possible about reimbursement for telephonic visits for medical, nursing, and peer services?
So I think the question is what's going to happen next, because obviously those are all reimbursable services as of right now. And the short answer would be, I don't know what's going to happen. I hope that they continue. We support them continuing. But again, it kind of depends on what CMS ultimately decides. But since I have the floor, can I make one comment?
Absolutely.
Sarah alluded to this, but I think this is really important to remember. While we're in phase 4, in almost every zip code in the state, I want us to remember that we're still in a pandemic, and we should still be doing the majority of our services in a way that makes both our staff and our patient populations feel safe. And so we need to be flexible, and we need to be ready to move